Well, I think molecular testing is crucial for these patients. Adenocarcinomas of the lung in particular, but for all subtypes of non-small cell lung cancer, molecular testing is critical and supported by the guidelines. And without molecular testing, appropriate treatment of non-small cell lung cancer is really not possible. The subtype of EGFR treatment is one that we understand quite well, has been the first targeted therapy option for non-small cell lung cancer with early introduction of first-generation EGFR TKIs. And obviously the patient was treated along the lines of an EGFR targeted therapy. It's important to note that for this subtype, immunotherapy is typically not effective, and therefore targeted therapy is the therapy of choice for these patients. I do recommend testing for molecular alterations in every patient with lung adenocarcinoma, but you could consider this for other histologies in non-small cell lung cancers as well. Typically, a patient that has a find of an actionable mutation has a sometimes several years lasting honeymoon phase that is chemotherapy free. It's important to note that for most of these molecular alterations, immunotherapy is not effective, and the identification of the molecular alteration is critical because we essentially, if these molecular alterations are missed, are still working in the range of chemotherapy with a significantly shorter overall survival. Patients that have a diagnosis of lung cancer are eager to get started. This is a very common clinical discussion. I try to explain to them that their diagnosis is not complete by the introduction of the histological part of their diagnosis, but that their treatment is much more guided by their molecular markers, and that those are required. That there's no urgency in the sense that an additional week or two for testing makes a big impact. Obviously, it's an additional stressor for patients, but the potential gains are so high that most patients are quite receptive to the idea of awaiting their molecular testing results before jumping on a non-specific therapy, oftentimes containing chemotherapy, and are willing to undergo testing, oftentimes including a repeat biopsy to obtain sufficient tissue for an appropriate selection of therapy for the individual genetic subtypes of lung cancer. I typically counsel my patients about the benefits, which typically allows for the introduction of the discussion about survival. I try to explain to them that oftentimes years are added on if molecular alterations are found, and that lung cancer is no longer the grim diagnosis that it used to be, that there's been significant progress made in the understanding of the biology of the disease that has now translated into a plethora of treatment options that are available already, and many to come in the very near future. So I'm quite optimistic about identifying these subtypes and I try to relay this to patients. I think this is incredibly important. Starting therapy in the absence of molecular markers is a tremendously difficult clinical scenario. Those are typically highly symptomatic patients, and they should constitute the minority of patients. But if acute treatment is needed, I try to resort to radiation treatment for the management of local symptoms. And if systemic therapy is truly required, I typically choose a combination of chemotherapy alone, typically a platinum doublet of carboplatin and nab-paclitaxel due to its high response rate. In these patients, I do avoid the introduction of immunotherapy. I want to make sure that the targeted therapy options are excluded at the time of adding immunotherapy. And the reason is basically a question of lack of efficacy, but also significant increase of toxicity that seems to be manifesting in the lung with introduction of TKIs following immunotherapy.